Hi everyone, hope all of you are doing great. Welcome back. In this module, we will go over the conditions that can easily be mistaken for anaphylaxis. Recognizing what's not anaphylaxis is just as important as spotting the real thing, especially in high pressure settings. Let's look at three common differentials of the anaphylactic shock that will help us in the better understanding of how to differentiate the anaphylactic shock from its differentials. So let's get started. So if you look at it, the vasovagal syncope is a common misdiagnosis of anaphylactic shock. Now, what are the key clues in that? In anaphylaxis, you will see there is tachycardia, in which your heart is trying to compensate the low blood pressure that was created as a result of a distributive shock, which is the anaphylactic shock in the body. What is tachycardia? That is your heart beating faster in order to compensate for the decrease in BP as a result of the distributive shock. Respiratory symptoms are also present in the anaphylactic shock, and similarly, a warm, flushed skin would be seen along with urticaria or angioedema that are the more common signs. Now, vasovagal events often involve bradycardia, in which your heart is not beating faster, it's beating slower than the normal. So, what's happening? In anaphylactic shock, you will see tachycardia initially, but in vasovagal syncope, there is bradycardia from the very first event. There would be PLAB, and there would be the quick recovery when the patient is laid flat because the blood supply to the brain has increased in those cases. Okay, so another very common condition that resembles anaphylaxis is known as septic shock. Septic shock is especially very common to be misdiagnosed as anaphylactic shock when there is hypotension which is present. But the timeline will help you differentiate between anaphylaxis and septic shock very easily because anaphylaxis is abrupt, it's immediate, it's quick, it's faster, it develops within seconds to minutes, whereas the septic shock would develop slowly and there would be history of some kind of inflammation and some kind of the infection in the body. Septic shock develops more gradually with a high fever and doesn't improve quickly with epinephrine injection, which is given in cases of the anaphylactic shock. And then another condition could be the asthma flare. So asthma flares can be very easily mimicked as anaphylaxis if wheezing is the main feature. So you have to first look for the extra signs like the skin involvement, like hypotension, like tachycardia, like stridor, and these symptoms will lean you more towards the anaphylaxis. Also, non-asthmatic patients don't just randomly have the severe asthma attack. There would be some history of the asthma in the past as well. When time is tight, your best clues are what's visible and how fast the condition came on. So you have to act rapidly. Always look at the skin for the skin symptoms. You have to look at the pulse and then the patient's context. And remember, if epinephrine works, you are probably dealing with the anaphylaxis. To close this section, remember, anaphylaxis involves multiple systems like your skin, your airway, and your circulation. And it comes on very, very fast. If there is ever a doubt, treat for anaphylaxis first, like giving the epinephrine injection stat. It can be life-saving, and epinephrine will hurt in most of these other conditions as well.